So I'm going to be chatting with you all about opioids and medications for opioid use disorder in adolescents. Um, in addition to what Jeremy mentioned, I'm also one of the NC Star Network faculty, and I'm very much appreciate the support that I've gotten from my colleagues here at MAHAC with putting these slides together. I don't have any disclosures to make. So objectives for this talk. So we'll start by examining factors that contribute to the development of substance use disorders in youth, adolescents, and young adults. This is something that I know we've spent a number of talks already today talking about. We'll also spend some time looking at the scope of opioid misuse and opioid use disorder in adolescents, review medications for opioid use disorder in adolescents, and then we'll spend the remainder of the talk exploring common barriers to treatment for adolescents with opioid use disorder, specifically looking at reviewing federal and state policies influencing youth with opioid use disorder accessing treatment. And then we'll end with a few case scenarios that hopefully will drive home some of those barriers and how we might be able to reduce them. So to start off, looking at opioid use in adolescents and young adults, as we've talked about already today, normal development creates vulnerability for substance use disorders more broadly. As we've talked about, just in our last talk with Dr. Jackson, adolescence is a time that normally involves increased risk-taking, novelty seeking, and trying to create new peer associations. It's that brain development time where the prefrontal cortex is not completely developed, but the other areas of the brain that are more involved in reward are fully there and are seeking reward. And it's, seeking those new experiences that can make adolescents and young adults more likely to develop substance use disorders. And in addition, when we're thinking about opioids more specifically, we know that these are brain-changing medications. We know that adolescents are very susceptible to those brain changes. And also, we notice that a lot of our patients, they're not exposed to opioids for the first time through their own prescription or from someone at school who, gave them a counterfeit pill or something along those lines. A lot of times our patients are exposed to opioids for the first time through a family member's prescription that was in the medicine cabinet. And that is more common than the patient getting their own prescription. We also see that with, substance use more generally, the age of first use correlates with more difficult treatment, less retention in treatment, and longer or higher risk of lifetime misuse. And that's what we see here. This is not looking specifically at opioids, but instead just drug misuse across a lifetime. And we do see that the earlier that a young person starts using substances, the more likely that they are to have lifetime misuse problems as time goes on. And sort of shifting gears there, looking more at opioids more specifically, opioids, as I mentioned, are brain-changing medications. They are medications that cause dependence if used chronically. And so we see that when individuals are prescribed opioids, this is looking specifically at prescription opioids, we are much more likely to have ongoing use at 1 and 3 years if that supply of opioids at the initial prescription is much longer. Or in this graph, we're seeing that the number of prescriptions that were written in that first occurrence of whatever the scenario was that the patient was prescribed opioids, the more likely they are to have ongoing use at 1 year and 3 years. Now, this does not specifically state that these people have opioid use disorders, but do just want to, highlight that, again, these medications are brain-changing medicines. They are medications that do lead to dependence, if even when just started for, short-term acute use. And so that, brings us to this specific study looking at adolescent dental patients who had wisdom teeth extractions. And they looked back at that and compared how many of the patients who were prescribed opioids following wisdom teeth extraction had opioid use disorder at 1 year, compared to how many of those patients had opioid use disorder if they were prescribed ibuprofen and acetaminophen. So when we look at that group that were prescribed opioids, we saw 6% of those individuals were diagnosed with an opioid use disorder at the 1 year follow-up. That's in comparison to less than 1% of the 1% of those who were prescribed ibuprofen and acetaminophen for pain management following extraction of wisdom teeth. And so as we look at this, that 0.4%, that looks much more like kind of just the general population number of people, adolescents and young adults, that may be diagnosed with an opioid use disorder at any time. Whereas that 6% number is much higher. So I want to take a moment with this slide and this study to sort of really emphasize that, again, opioids are brain-changing medications. And when we're seeing our patients for issues unrelated to, use disorder treatment, we should really be cautious and thinking sparing and using opioids sparingly and only when they're absolutely indicated in our adolescent and young adult patients, because there is such high risk. So moving on to kind of examine more specifically at opioid misuse and use disorder in adolescents. So this is the good news, and I think this maps onto what we've been hearing in other talks. Opioid misuse is decreasing consistently among adolescents, as we are seeing, use of other substances decreasing. And opioid use disorder is far less common than opioid misuse. So in some recent literature, opioid misuse probably looks at, we see probably somewhere between like 3 or 4% of adolescents and young adults reporting opioid misuse, whereas less than 1% are diagnosed with an opioid use disorder. In North Carolina, that percentage of people, of adolescents with opioid use disorder is perhaps estimated to be slightly higher, at closer to 1%. Now that's contrasted with the bad news in that despite opioid use on overall going down, opioid use disorder diagnoses in adolescents and young adults overall going down, the opioid overdose rate and mortality from opioid overdose still remains very high. We saw a significant increase in opioid overdoses among adolescents between the 2018, 2019 to the post-COVID pandemic, 2021, 22. We don't really have much data beyond that. It does appear that has sort of plateaued going forward, but we are still seeing many more opioid overdoses than we did 5-7 years ago among adolescents. And to give a scope of kind of like what is the problem nationally, it's estimated that on average 22 adolescents and young adults die of an opioid overdose on a daily basis. So extrapolating that out over a year, we see that number increases to over 1,000 people a year, 1,000 adolescents and young adults dying from opioid overdoses. So this was actually, I think, a slide that Dr. Jackson had in his last talk as well, because I know when I've heard this talk that I'm giving before, or I've given this before, at this point I'm thinking, yep, I hear you. Opioids are a brain-changing medication that there is definitely risk of addiction with those. Um, we know that there are adolescents out there who are misusing opioids and have opioid use disorder, but I am just not seeing that in my practice. I'm a primary care doctor who sees adolescents and young adults all day, every day. And even for me, it's a very small percentage of my patients that I'm seeing for opioid misuse and opioid use disorder. And so we see that most patients who have a use disorder in this adolescent age group are not seeking treatment. Um, and a small percentage of those patients believe they do need treatment, but perhaps don't know where to access care. So I'm hopeful that this presentation and this conference today empowers us as providers working with young people to sort of help identify those folks who are misusing or have use disorders but are not accessing care, how to motivate those patients to seek care, and then break down some barriers when that adolescent is eventually in front of you seeking treatment. And so the rest of this next part of my talk, I'm going to be spending some time reviewing medications for opioid use disorder with a specific focus on buprenorphine as an option for treating opioid use disorder. As we've talked about before, and in other talks today, I do want to emphasize that this is a piece of the puzzle of treating adolescents who have opioid use disorder. It is not necessarily the only thing that we need to do, but I do think it is a piece of the puzzle that should always be considered when we're seeing adolescents with opioid use disorder. So more broadly, why should we consider medications for opioid use disorder? Why do they work? So specifically opioid agonists, so that being methadone and buprenorphine, we see consistently that these medications reduce overdoses, they reduce illicit drug use, they reduce transmission of infectious disease, specifically hepatitis C and HIV. At a health systems level, we do see that these medications save a lot of money for health systems. I'm much more focused on the individual in front of me as a primary care doctor. And this next bullet point is really what drives home the benefit of medications for opioid use disorder, is that people who are on medications for opioid use disorder are far less likely to die from an overdose than those who are not receiving medications for opioid use disorder. And I think that's a really powerful statement for us to think about and talk about with our patients, is that these are truly life-saving medications when they're used appropriately and in the right patient. There's another medication that we'll talk about a little bit more later is naltrexone, another one of the medications used for opioid use disorder. There's mixed evidence for that mortality benefit in naltrexone, and it's a medication that has been less studied in adolescents. So a little bit briefly about buprenorphine. So it's a partial agonist of the mu opioid receptor. So I think of that, what that means very simply. So if fentanyl or oxycodone or hydrocodone is a full agonist, meaning that it hits those opioid receptors 100%, I think of buprenorphine as hitting that receptor about 50%. It is also a medication that has a very long half-life, meaning that it's going to be in our patient's system for quite some time. It also has a really high affinity for that opioid receptor. And what that means is that it binds to the receptor extremely, extremely tightly. And that can be beneficial in blocking other opioids from binding to that receptor. And then it can also be problematic in our patients that are using opioids regularly and have a dependence to that substance that that substance of abuse or the substance that's developed their opioid use disorder. It can actually displace those that medication, that substance off the receptor and lead to something called precipitated withdrawal, which is something that needs to be overcome and thought about cautiously when we're starting our patients on buprenorphine. And along with that long half-life that I mentioned, it stays on the receptor for quite some time. So buprenorphine and the most commonly prescribed formulation of buprenorphine is the buprenorphine naloxone. So how does that work? It's a medication that is usually dosed between 8 and 24 milligrams. The typical maximum is 24 milligrams. And there's different routes of administration. For buprenorphine naloxone, that is typically either a sublingual film or a sublingual tablet. But then there are also long-acting injectable forms of buprenorphine without the naloxone that are given as a subcutaneous depot in a healthcare setting. Currently, those are only available in brand name, but those are also options for our patients that we're considering buprenorphine for. I mentioned, buprenorphine naloxone generally being considered the first line medication when we're considering buprenorphine versus buprenorphine naloxone, meaning the combination product versus the mono product. And the reason for that is that naloxone that is included in the buprenorphine tablet or sublingual film is placed there to help discourage non-therapeutic use. It's thought to have negligible absorption into the bloodstream, and it's also thought to reduce diversion to illicit market. It is worth notable that in our patients who have severe hepatic impairment, not very common in our adolescent and young adult patients, but in patients who have Child-Pugh class C liver disease, we do want to avoid that naloxone piece of it and may consider being cautious with buprenorphine in general. I mentioned those things, but I don't want this concern about non-therapeutic or illicit use of buprenorphine or diversion of buprenorphine to dissuade people who are interested, who might consider, providing this treatment to adolescents and young adults. In the United States, we see that buprenorphine is generally not considered a drug of abuse, and that diversion or illicitly obtained buprenorphine is generally taken to treat opioid use disorder. And it's our patient that can't access care for whatever reason, lack of insurance, lack of transportation, whatever it may be, that is using buprenorphine that they obtain illicitly to treat their opioid use disorder. And so buprenorphine, in addition to it being one of the medications that I can prescribe from my clinic office, I think it is also super beneficial for treating opioid use disorder because of its safety. It has significantly less overdose potential than full agonist opiates. There's a ceiling effect of any potential respiratory depression. So taking more and more and more buprenorphine doesn't lead to more and more and more respiratory depression. There's negligible to no psychomotor or cognitive impact of this medication, meaning that patients can still function in school, in their work lives, in their operating equipment, motor vehicles, etc., while taking this medication. Patients also don't experience tolerance to buprenorphine like they do full agonist opioids. So whereas our patient who has a use disorder using fentanyl or oxycodone likely will start using more and more and more of that substance to get the same effect, we see that in general that's not seen with buprenorphine. There's also an antidepressant quality to buprenorphine as well as compared to full agonist opioids. So in general, when we're starting buprenorphine, this is a talk in and of itself about the ways to start buprenorphine in adolescents and young adults. But in general, a lot of times it's just being curious and non-judgmental and talking to that patient in front of you and just asking them, have you ever used buprenorphine? before, whether it was prescribed to you or not. And more often than not, these days, the answer is yes. And you say, great, what dose worked for you? So now that we've talked about, buprenorphine and medications for opioid use disorder, I want to spend the remainder of the talk reviewing barriers that a lot of adolescents face when trying to seek care for their opioid use disorder and start medications for opioid use disorder. I'll go into each of these more in our next slide, but these are just in the next few slides, but these are just a few of them. Limited providers who will prescribe medications for opioid use disorder to adolescents, providers not knowing the laws, low motivation from the youth and adolescent to seek treatment in the first place, stigma, lack of insurance, and difficulty obtaining that medication. So I want to talk about stigma, and stigma related to medications for opioid use disorder exists on all levels of this. So there's stigma at the patient level, the parent guardian level, the caregiver level, and the provider level. And one, I want to focus in on the provider level stigma just a little bit here. I often hear, in adolescents and young adults in general, we want to think of medications as a last resort. We want to think of medications. I often hear, we could consider medications if things got worse. But when it comes to opioid use disorder, I feel strongly that often the risk of waiting until things get worse is too great because, that risk of overdose from opioids is so high. And provider stigma limits access to evidence-based treatment, and expanding access to medications for opioid use disorder reduces stigma overall. And we see that with these major society guidelines, where the Society for Adolescent Health and Medicine, ASAM, the American Academy of Pediatrics, all recommend considering medications for opioid use disorder as as an option and part of the care for adolescents who have opioid use disorder. Prescribing buprenorphine to adolescents, this is an FDA-approved medication for those ages 16 to 18, and it's recommended for patients with severe opioid use disorder without age limitations. And this is covered by NC Medicaid down to age 16. And as of 2021, patients no longer have to have a failed withdrawal attempt prior to that being covered. A little bit more detail about each of the medications for opioid use disorder. We have buprenorphine, naltrexone, and methadone. Buprenorphine is the only one that is FDA approved for those less than 18. Naltrexone, we don't have a lot of evidence of its benefit in adolescents, and we need more research. Methadone is an option with consent of a parent or guardian for those less than 18. And as of 2024, methadone also does not require an unsuccessful detox attempt prior to trying methadone for treating opioid use disorder. And then this is another point that I want to emphasize is, we could have a really terrific visit with our patient, have a really informed conversation, make that decision that yes, starting buprenorphine is the right thing for my patient today. But ultimately that prescription has to leave my office, go to a pharmacy, and that pharmacist has to fill the prescription. And I've had patients, face barriers of getting that prescription at the pharmacy. And that's why I think it's really important that we all communicate as best as possible. I've talked with my clinical pharmacist colleagues here at my institution, and they don't see the clinical context that we do in the office visit. It's really important that when we're prescribing this medication, we pick up the phone and call the pharmacist and be like, hey, this is what we're doing. On my prescriptions to the pharmacy, I often include my cell phone number so that if questions come up, that pharmacist can reach out to me directly. And the other barrier that often exists is not understanding kind of those laws and regulations. So specifically that comes down to what are the laws related to consent and confidentiality in treating substance use disorders in adolescents. So the North Carolina General Statute does specify that physicians can accept a minor's consent for substance use prevention, diagnosis, and treatment. We don't need emancipation or parental consent to prescribe buprenorphine to those less than 18. Now, as we talked about before, the family, the parent, the caregiver, the guardian dynamics are super, very important. And I think it's very important that we involve um, parents and guardians and caregivers in this care as often as we can. But if there are, extenuating circumstances, you can see that patient um, without parental or guardian consent. And so I'm going to spend the last couple of minutes here just going over a couple case scenarios to just sort of drive home a couple of these points that we've talked about today. So case one, you receive a call about a 16-year-old patient with fentanyl use disorder and suicidal ideation. They've been at a local inpatient treatment center getting psychiatric care, and they're about to discharge. They have outpatient psychiatric care arranged, but they contact you as their primary care doctor to see if you'd be willing to continue the buprenorphine naloxone. So what do you do? And so for me, that answer is yes, absolutely. Would love to see that patient. And I would absolutely encourage that adolescent to bring a parent or caregiver with them to that meeting. I frame it as it's really difficult to manage chronic disease and chronic illness on your own, and having that support person, having that person who is helping you along this journey is super beneficial. Legally, you can see that patient without them present as a physician or medical provider, but always encouraging them to bring those people with them. Case two, you've been seeing and treating a 17-year-old patient who has a history of fentanyl use disorder, who's now 3 months into recovery. They're stable on 8-2 milligrams of buprenorphine naloxone daily, and they're connected to behavioral health. The patient's mother comes to every appointment, and today they are mentioning that they would like their child weaned off of buprenorphine products. What do you say? And so this brings up the question of how long should MOUD be continued? And the answer is we don't know. But there is research indicating that there's a high return to risk use when people are tapered off of buprenorphine, especially when it's early in recovery. And to me, when I'm talking with my patients, it's an opportunity to destigmatize medications for opioid use disorder, frame opioid use disorder as a chronic illness, and have that conversation of being like, from a medical perspective, I strongly believe that this is a medication you continue as long as it is providing you benefit, as long as it's helping you stay in recovery, controlling cravings, controlling withdrawal symptoms. As we talked about, as I mentioned earlier, discontinuing buprenorphine early in recovery is associated with a really high return to use risk. And having that conversation is an opportunity to discuss and inform. The last case that I will review is about a 17-year-old patient who was unhoused, previously dependent on prescription opioids, but responded well to buprenorphine and was stable for 5 months. And now they've told you that they've returned to intermittent occasional prescription opioid use. What do you do? And so I think this is an opportunity to, talk with our patients about harm reduction. How can we, if they're not ready to change that prescription opioid abuse completely in that moment, making sure they have access to naloxone. If they're using injection substances, making sure they are aware of clean injection supplies and where to get supplies to test the drugs that they're using. It's also an opportunity to continue the buprenorphine. Return to use is not a reason that we shouldn't continue the buprenorphine and help try to keep them stable in remission, get them back to remission. So just a few take-home points for my talk today. I just want to emphasize that adolescence and that young adult period is it's a time where people are exceptionally susceptible to developing use disorders. And I hope that, I can encourage you all to consider MOUD as a safe and effective option that is it's one of the options and is part of treatment for opioid use disorder in adolescents. And providers can increase access to this by understanding current policies, laws, breaking down stigma, and working with their clinical pharmacists.